Let us pray.
Can someone else pray? It seems to have gone out.
Yes, I think so.
Okay, let us pray. Mighty God, we thank you for another afternoon together. Lord God, as we are about to start this session, I pray, Lord Jesus, that you will just guide and protect us. Help Dr. Mac, Lord God, that she'll be able to impart the notes in an effective way, mighty God. I pray, Lord God, that you grant us with understanding and the knowledge, Lord God, in order to be able to understand what she's saying. Lord Jesus, I pray, Lord God, that you will just keep us, and I pray, mighty God, that you will just have this session run smoothly. I pray, Father God, for Kojo, Lord Jesus. Give him the patience, the wisdom, and the understanding on how to operate what we're doing right now, mighty God. And so right now we give you thanks for everything that you have done. In Jesus' name, amen.
Amen. Thank you so very much, ladies and gentlemen. And the class for this evening is officially on. And we are live. And I want to again thank you for taking the time to come. Just a couple class announcements. I believe that there's going to be an exam on the 4th of June. Mr. Nami, could you clarify if that's true?
Yes, that's
the
true.
Exam?
Yes.
Okay, the exam is going to be on the 4th, which is, I believe, my goodness, it's next week. Is it next week, Thursday?
Yes, it is.
Okay, it's a take-home exam, so you'll be getting cases and an essay, it's primarily cases and essays, or one essay to choose from. I'll be sending that exam to the bodies, to the academic bodies as over the weekend. I have also not received tools evaluation. I cannot do any grades until I get it. And of course, when group 3 and 4 presents tomorrow, I'm going to need that right after evaluation of your members.
Dr. Mac?
Yes?
Read the take-home exam. When is it due? When do you expect to get it back?
The same day. It's to be loaded on the portal. There's no take-home exam.
But you just said that.
Not take-home. No, I did not. Did I say take-home exam? I don't remember saying that.
Yes, Dr. Mac, you said take-home.
Yes, well, my apologies. It's probably a senior moment. No take-home exam. It's going to be an in-class exam, but it's open book, I meant to say. My apologies.
Okay.
Okay, Dr. Mac, can you just give us an idea of the structure of it? In other words, the syllabus had made mention of multiple choice and short answers and vignettes and so. Can you give us an idea what the structure of the exam is going to be like?
And the topics that we could focus on?
Oh yes, and the topics that we need to focus on.
This is, well, you don't need to know topics. It's an open book exam.
No, Dr. Mac, but we have covered a wide variety of material, so it would be nice if we could be able to zone in on what to expect. The areas.
Well, there'll be a child and an adolescent case, which is mandatory to select.
So select from one of those.
I'm not certain if I may give you one to choose from, but I'll think about that. But there'll be 2 cases, and
two cases for the entire exam?
No. Oh no.
How many cases?
I did say 2 cases, but I'm saying that there may be a couple essays to write. So I will decide.
Remember,
yes.
Remember, it's a 3-hour exam.
Yes, but students, this is a take-home exam. The exam could have been done. I could have done the take-home in an hour and a half.
Take
That
home? You keep saying
No,
take
doctor.
home.
Dr. Mack, you keep saying it's a
In
take
the
home
house
exam.
exam in an hour and a half.
No, but
Dr.
Dr. Mac,
Mac.
you're a
Dr.
professional.
Mack?
Huh?
Oh Lord.
Oh, and a
Hold on,
half.
You're a
hold on. Hold
professional.
on, guys. Hold on. Everybody talking at the same time and you're going confused, Dr. Mac. Hello,
Dr. Mac,
Jean. Ask your question.
no, I'm saying, Dr. Mac, it would take you like an hour to do both cases because you're a professional, but we are not.
But you are professionals.
We're budding professionals.
Anyway, Dr. Mac, here's my question now. If we are supposed to do it, in 3 hours, because if we're supposed to hand it in at the same time, that means we're supposed to do it in 3 hours. My
Yes.
question is this: a couple of cases can be done in 3 hours because your type of cases and your type of essays, you don't want 2 lines. You require pages and reams of paper.
Oh,
I suggest that you bring your laptops to do the typing, that it can be uploaded on the Moodle platform.
oh my God.
Dr. Mac, here's what I'm saying. I'm a little bit nervous and very, very
Why are you
anxious
nervous?
right at this moment.
But why are you nervous?
Because here's the thing, Dr. Mac. Remember, I went through one already, you know. And my thing is, okay, we're getting 2 cases, you said.
Mm-hmm.
2 cases to do both cases, or to choose from one.
To do both cases.
Oh my
Okay,
God.
and will it be done? And will it be done? Sorry, and a choice of one essay,
Yes.
so 2 cases and a choice of one essay.
That's correct.
Okay, so in other words, you're doing three questions.
3 comprehensive questions. Yes.
Okay. So Dr. Mac, that I still
Yes,
not
Miss-
comforted. I still
Yes,
not
Miss-
comforted.
You're
As-
competent, but you need to you need to learn to go on a limb to fall off. That I can catch you. I'll catch you.
Here's where I'm not comfortable, Dr. Mac. Because
Yes.
your cases have about 6 different pieces to it.
Even though I'm going to hold you gently and put you down on the floor, you don't have a hard blow.
Dr. Mac.
Yes.
So these cases are these cases going to be just like the ones that we're doing now, where you just ask?
No, this is a treatment case. It's not psychopathology. All I'm required to do in that treatment is to determine the diagnosis and possible differential diagnosis. But nothing like what happened in the course last time. No.
So Dr. Mac, between now and then, can we at least do a practice one to get an idea of what it is that you'll be looking for? Because you mentioned something about differential diagnosis. Differential diagnosis mean that whatever other diagnosis we can get from it, which we have not really been looking at.
No,
we have just been looking at the main diagnosis.
No. Just focus on the diagnosis and treat it. That's all I want you to do.
But using the treatment plan setup, or just is there a format that you want
treatment and a treatment? We'll do the treatment plan this evening. That you will not really, let not your heart be troubled. I will
but it is.
Dr. Mac?
Why is your heart troubled, ladies and gentlemen? Miss Williams?
Yes, ma'am.
You're a banker.
Yes, ma'am.
If you come to me for advice and you said to me, "No, well, we'll fix the problem," I'll catch you gently and gently lay you down. You have to learn to fall off the cliff.
But I'm not going to make you drop in the first place, Dr. Mac. I will not allow you to fall, but you want me to drop.
No, I won't do that. No. See, I'm giving you a take-home. I keep saying take-home. I'm giving you an in-house open book exam in the class. I have never done that before.
So we need to go to school? So we need to go to school for this? So we are expected to go to school.
Dr. Mac?
Yes.
Dr. Mac?
Yes.
You are saying we have some problems here. First of all, in regards to uploading it on the Moodle, not everybody is able to type as fast as you would want them to in order to meet that 3-hour time span. That's the first issue I have. The second issue is, as well, I'm just noting from Rowena, is that the next class begins on June 4.
No, but no. But
No, they change it, Rowena. They change it to Monday.
Okay.
So don't jump the gun here. We have
An
fixed it.
email came out from Jessica saying that the exam would be on the 4th, and so the class has been moved to the Monday.
Okay, so you have
changed.
time to do it. If people can't finish within the classroom, then we'll have to arrange for you to take it home, but it has to be uploaded by a certain time, preferably the same day that I can start reading.
Dr. Mac, why don't we just decide to
Michelle, 1 second. I'm just trying to get these things across. What's his name? Robert is asking you what is the frame of the exam. In other words, the content. What exactly is it that we should focus on what's in the syllabus, or are you going to give us an outline?
No, focus on what is in the. I see it. Focus on what is in the syllabus. I won't give you anything outside of the exam. Why would I want to do that?
Are you going to give us a guideline?
What guideline?
Dr. Mark, we have done quite a bit of material, you know. We've spoken of it. It's a huge topic, and
it's a very big. Well, basically, what I wanted to focus on the cases is being able to tell me what the problem presenting complaints are, what are they, and I want you to be able to tell me, give me the diagnosis, tell me what the referral is, how you're going to deal with the referral. In other words, pay attention to the case conceptualization method. Okay? Pay attention to the case conceptualization method of the exam, and you tell me what the diagnosis is, and then I want you to be able to look at, are there any Rotter's indicators? Are there any risk factors that is going to impact treatment and is going to impact the diagnosis for you to provide a suitable intervention? And then I want you to also, once we do the treatment plan this evening, we do a treatment plan, come up with one, and then you are going to do a treatment approach. And as what anyone that is going to, one or two that is going to fit the case in question. So if you want to do cognitive behavioral for a child, or you want to do Alderian for it, fine, but justify why. So you need to look at the concepts of what the concepts, what is the key concept, what is the theorist saying about the case, and what are the treatment strategies that are used in the case.
So you want that for both cases, all that detail for both cases?
That's correct.
Oh my God.
This is a treatment class. What? Oh my God, what?
Nothing.
No, you don't need to worry about that. You have an open book.
Okay. Michelle, you can go ahead now, darling.
All right. I don't want to take up too much time with this exam. I have to start this class pronto. But there's no need to worry. I'm not going to kill you. Dr. Mack is not out to murder anybody. That is metaphorical anyway. It's for you to be able to get practice from this, but it's for you to get to be able to apply what you have learned in the class. It's more practical than anything else.
Dr. Ma?
Yes?
I'm reading something from Nordell.
It's there already.
Okay.
She's asking if we can get the day for the exams. I don't know. The people there have to decide that. I can't. Because if you do a take home, it's going to mean that you're going to turn it in a certain time. I'm not expecting anything past that weekend. Nothing. It must be done. So people need to decide before I leave it this evening that I can talk to the dean again about this. And Mr. Nami has to make to proctor the exam. Somebody has to be there. So students need to make a decision.
Honestly, Dr. Mark,
Mm-hmm.
If you are going to suggest that we upload it on Moodle,
yes,
I really don't think 3 hours is gonna cut it. So I think maybe it's best we do the take-home style and upload it within the weekend that you're suggesting.
Just so you know that there's a deadline, and I'm going to adhere to the deadline. If that's the case, Mr. Nyami has to agree because
that's it. Everybody else and Mr. Miami is in agreement.
It's fine with me. Whatever the decision is.
Are you okay with that, Mr. Nyami? As long as okay, I'm flexible. I'm going to stick to the deadline this weekend. I'm not going to. Nothing is going to be held over. Okay. So
the deadline is this weekend. You're saying?
Well, no. Remember, no.
That's
the deadline.
Oh.
This weekend.
Deadline is what?
The exam is on the 4th.
So now, when do you suggest that you're the one who has to guide the uploading? When do you suggest that they turn it in? Because this is, I am not going to have it next week. I just don't have that time. I need to.
No, if you're gonna have the exam open on the 4th of June.
Yes.
Then you would have to decide how many days you give for them to hand it in as a take home.
Okay, so.
Dr. Mark? Dr. Mark?
In addition, let me finish, please. In addition, you'd have to also make sure that we inform the dean and that she's in agreement.
Yes, the dean has to be in agreement with that. Yes.
Okay.
Dr. Mark, if the exam is on the 4th, which is a Thursday, and you're giving us the weekend, which it either means we are to hand it in on the Sunday, which is the 7th, or because class starts on the 8th. So if you're giving us the weekend, it will be the 7th of June.
Is that I don't know. Is that I don't have a calendar in front of me right now.
I'm looking at the calendar, Dr. Mark. I'm looking at the calendar. Dr. Mark, I'm looking at a calendar. I'm looking at a calendar. I wouldn't be giving you out of my head.
Sunday.
Okay. I'm looking at the calendar.
All right. So that's a Sunday or when?
That's a Sunday.
So are the students okay with having an exam final date the day before the next course starts?
Yes.
Yes.
I'm going to document the students because this I'm going to document this to the dean that this is agreed on.
Wait, Dr. Mac. And this take-home exam will still remain as the 2 cases with the 1 essay, right, Dr. Mac? Nothing will change. Dr. Mac?
Don't push it. Don't push it, please.
No, that's what you gave us. 2 cases and an essay. So that will remain the same in the take-home, right?
I need to think about it.
Oh Lord.
Before the end of the evening is up.
Okay.
All right. We're moving out of that. We need to start. We need to. So let's have students looked at the child interview, the notes that were uploaded? Did you look at it? I told you to look at it from Monday. Did you look at it? You were told to look at it.
Oh. Yes, Doctor.
Students, did you look at the child interview and history? Did you look at it? I'm not hearing.
Yes, Dr. I looked at it.
Okay, that's 1. Did other students look at it? Ms. Williams? Miss Mayor, the 2 mayors, and Miss Cameron, did you look at the child interview? Did you read it?
No, Dr.
Yes, I beg your pardon?
I didn't read it. I'm sorry, Dr. Mac. I didn't get a chance to read it.
Okay, well, I don't have, this is why I said to students, this is why I have a responsibility to the class to read it. I don't think I want to go through this. It's pretty straightforward, except to look at quickly with children. I'm not going to spend much time on the interview. We will not. I want to go straight into the treatment plan. But just to say that the interview itself is about getting a detailed history of the child. Getting a detailed history of the child and the child's relationship in the environment. So when you're doing the interview with a child, when you're doing the clinical interview, you're not just interviewing the child, you are interviewing the parents. So the interview is specific. It is specific, it is comprehensive. It is parent-driven primarily. Even though it's a teenager, it's still parent-driven. The guardian has to give you information as to what is happening. It's specific, it's comprehensive, it's goal-oriented, and the guardian has to give you information. So normally you will have a consent for treatment for you to even discuss anything, discuss treatment. So the clinical interview is part of the case conceptualization method. Pay attention to this question, ladies and gentlemen, it may show up. I'm giving you some hints. So it's a screening device through which the clinician rather gains an understanding of what the problem is. What are, in other words, what are the presenting complaints? What are the presenting complaints? And hence a diagnosis is generated. Hence a diagnosis. Yes.
Someone on YouTube, Marshall, is asking what the topic is. They didn't get the topic.
Oh, beg your pardon. The child interview. The child interview. Or the child and adolescent interview. My apologies. Thank you for that. I should have given the heading. So basically, just know that I did say it's part of the case conceptualization method. So the interview has three basic.
I'm sorry, Dr. Mack. Did you finish with the point about what are the three presenting complaints? Screening device through which the clinician gains something or another.
An understanding of what the problem is.
Okay.
With a view to deriving a diagnosis. And I was about to say, and I'll say before I forget, that that the interview has three basic components, or functions. Components or functions. Three basic components or functions, and one, it is diagnosis, which is describing the client's concerns. Diagnosis, which describes the client's concerns, or child client's concerns, or the parents' concerns. And of course, diagnosis is going to lead to case conceptualization or formulation. It will lead.
That's number 2, Dr. Mack?
Yes, the case conceptualization or formulation,
okay,
which is defined as clinically understanding the client's concerns. So diagnosis describes it, case conceptualization clinically understands the concerns. So you're understanding it, you're operationalizing what you're hearing. what you're hearing, what you're seeing, what is being reported to you. And thirdly, case conceptualization leads to treatment planning. Treatment planning. And this is addressing the client's concerns. Addressing the client's concerns. Quickly, interviewing the child is another heading I'm going through. Interviewing the child. The notes are online, so I'm just going to go through some more important concepts. I'm not going verbatim. I'm just picking some important things through the notes that we can get to the treatment plan, which is important. You need, for children and adolescents, you must use open-ended question. You must use open-ended questions. Example, tell me more about that feeling. For example, tell me more about that feeling. You must consider the child's or teenager's developmental level and also cognitive processes. You must consider the child or teenager's cognitive or developmental level. So basically, your role is to instill trust and a very so you're building a rapport with the child, because not all some children won't talk to you if they don't trust you. They know when you're not being true or you're not honest. They can pick it up. So with children, they have to show respect and trust. So you need to let the child know that you ask them, do you know why you're here? Do you know why you're here? Do you know why you're here in treatment? So you need to instill rapport with the child for them to determine why they're in treatment. They may not want to be there. And so your role is to make them feel comfortable, safe, and to understand why they're in treatment. So that's some basic guide of them. You can read it online if you need to. And again, I said pay attention to this question. A word to the wise is sufficient. Quickly, some characteristics of the child interview. I just want to go that through with you. It's quite a lot, and I don't have time to really go through what I intended to. But let's look at some characteristics nevertheless. As I said before, the child must know why they're there. So in other words, you need to ensure the child, because sometimes young children especially think that the reason why they're here to see that they did something wrong. So you need to know, the child needs to understand why they're there. And you can respond to the child or the teenager the following. This is a suggestion that I read it to you verbatim. Your parents and teachers ask me to see you. You can probably write this later, but I just listen. If you have any questions, ask. Your parents and teachers asked me to see you so that I could help find out why you are having trouble at school or at home. I will be asking you some questions. Some of the questions will be about your feelings, your thoughts, and behavior. Any questions? Are there any questions?
No, Dr. Mark.
No, Dr. Mark.
No, it's all right. No questions.
Okay, so it's clear.
Yes, it is clear.
Okay, so the guide, so other characteristics that you must absolutely, that's an absolute, structure equal time between the client and the parents. I know it's hard, but you're going to have to do that because, as I said, the parents have a right to know what's going on. You absolutely must conduct a mental status exam with the child. And the mental status exam can comprise appearance, how is the child looking? Is the child's behavior? Is the child fidgeting? Is the child's what's the child's emotional state? What you're seeing? Does the child make eye contact with you? Level of arousal. Is the child calm, cries, or agitated? Level of arousal. Is your child being calm or agitated? Is the child anxious or aggressive? Are there any unusual behaviors? Are there any tremors in the child? Slow, repetitive, involuntary movements. Tremors? Are there any slow, repetitive, or involuntary movements? Slow, tremors, repetitive, or involuntary movements. Any psychomotor activity? Any psychomotor activity? In other words, hyperactivity, poor boundaries with you, they want to sit on your lap. Those things are clinical indicators that you need to take notice of. Let's look at mood and affect. I'm just taking a... Yes?
One quick question before you move on. With the mental status exam, would it be the same one that you would use? Okay, do you have a different examination for the child as you do for the adult, or it's the same?
No, the same one, but in a different way. I mean, you are noticing things. Good question, I should say. In the same format, but you'll ask the questions differently. You're more in a child. You will more take note of what you're seeing of signs than symptoms. Than what the adult is actually telling you.
Okay.
But you pay attention to mood.
Okay.
The child's mood is the child depressed and irritable.
Okay.
Child able to focus, paying attention, is your concentration. What about affect? Affect in terms of range, is it restricted, blunted, etc.? Speech, yes?
Dr. Mark, I was just wondering, is all that you're saying now, are they in your notes, the handouts that you sent us?
I believe they're in the notes. I don't want to go through this too much. This handout, I believe, is on the platform, the Moodle. So I really don't want to go through this. You can read that on your own.
Okay, Doctor. Yes, thanks.
I need to get to the treatment plan. So but people did not read that that interview, but I just want to underscore some things in the interview. So I did say that one other characteristic of a child interview, again, this is on the Moodle, so I'm just underscoring some things and adding some things as needed, that you must look and observe the child-parent, child-teenager guardian interaction. It's very important. It gives you an idea of the nature of the family structure. Gives you an idea of what's going on with the parent and how the child interacts with the parent. So note that. That gives you the information.
Can you repeat that again for me, please, Dr. Mack?
I'm saying you need to note very specifically and very carefully the interaction between parent and child, parent and teenager, parent and guardian. I mean, parent and or teenager and guardian, child, teenager, guardian. It is extremely important for you to know the interactions. Does the child sit far from the parent? Do they sit together? It tells you the nature of the attachment. Is it one person who brings a child? Who brings a child to the session? Note that you must get consent from the parent. So if a neighbor brings a child, you really shouldn't see that child. You must get consent for treatment from a parent.
Now, Dr. Max, supposing the parent we deal with a teenager and the parent says to the child, well, you need to go to counseling at the counseling center, and the child decides that he or she does not want to go. No, that's not the question. Assent is what is given by the child to therapy?
You what?
Assent.
No, the child cannot. No, there can be assent. No, you cannot see the child. The child doesn't want to come. There's nothing you can do until the child.
The question I'm asking, Dr. Mack. Assent is what is given by the child.
Assent is given by the child to engage in treatment.
Okay.
Consent is the parent. Yes.
That's what I'm asking.
Okay. I thought you meant that the child cannot has to give assent generally for treatment. No. The parent, a legal document has to be signed by a guardian.
Okay. So in other words, the child just can't decide by themselves that they want to go to therapy, no? Okay. No,
they can come, but legally, the parents have to give permission for you to touch them.
Okay.
Because you can't see that, you have to have legal consent, a signed document by the child's guardian and the child's parents.
Okay, Doctor.
We have seen a lot of problems. In other words, even with divorce, be careful. Do not see a child, if a mother brings a child, they're divorced. Make certain that you get the consent of the father. Am I making myself clear to you?
Yes, Dr. Mann.
Ladies, other students, am I making myself clear to you? People from YouTube.
Yes, Dr. Mark.
Do not see the child without the father. You're going to run into serious trouble.
So, Dr. Mark.
Yes.
You're saying that if the parents are getting a divorce, both parents have to give consent that you can see that.
Yes, it's advisable to get it. Yes.
But what if the father is not interested in just going about in business?
Well,
and the mother moves, and the mother see where, and the mother see
documented somewhere that the father is not in the child's life.
Right, and the mother sees it necessary for the child to be home.
Yes, but you cannot assume anything. You must ask, because I work with children and parents, and the parents didn't even know on you. It's my rule of thumb to ask parents, the father or mother, whoever, to say, we need to see you. And most of the time they come.
Okay.
But you need to involve both parents.
Okay.
That's the rule of thumb.
Understood, Dr. Mann.
All right, quickly, because as I said before, I'm not going to belabor this. This can be read on the notes. But just let me just go through steps to interviewing young children. Steps to interviewing young children. Somebody's asking consent from a guardian, legal guardian. Yes, you must get consent. Okay. With a young child, I'm talking about a child, you can see children from at least, well, 4 to 7. Be concrete. Communicate in the third person. Be concrete. Communicate in the third person. That is, for example, so how does the alligator feel about that? So how does the alligator feel about that? What would he deal with his problems? For example, Johnny met an alligator and the alligator had some problems like Johnny's. What would the alligator say about his problems and how would he deal with that? That's the third person. The child projects, is likely to project those feelings, unsafe feelings onto the object and be able to feel safe, clarify and say what the problem is. Is it clear? Is it clear?
I'm sorry, Dr. Mack, I was a little bit distracted. Sorry about that. Could you just be concrete in communicating? What's that, Dr. Mack?
Be concrete, communicate in the third person.
What is this in relation to, Dr. Mack?
Steps to interviewing young children.
Okay, thank you.
I'm giving you something. I'm not going to give all of it. You need to read this information. It may show up again. I keep warning people. Be concrete, communicate in the third person. For example, how does the alligator feel about that? What would he deal with his problems? That's a third person.
This is number 1 or number 2?
That's number 1.
Thank you, Dr. Mack.
2.
Sorry, I thought number 1 was get consent from parents.
No, no, that's general guidelines.
Okay, all right then.
Okay, 2. When a child says, I don't know, children say that, I don't know, miss. They really mean, I don't want to discuss this. When a child says, I don't know, they mean, I don't want to discuss this. So how would you deal with that? You can say, well, it seems that, you know, little Johnny is having difficulty talking about feelings. Maybe when we go to the playroom, we can talk about those feelings in a better way. You make a note in the intake. For older children, yes, it instills safety and security, that they're able to project themselves onto an object in the third person. That's how children are. They're safer. They do projection onto an object. So if they want to project their feelings onto the alligator and says the alligator says it, then you are able to know what they're feeling.
Dr. Mark, I have a question, please.
Yes.
Okay. Young children, for example, between the ages of 4 to 7, if they are brought to the clinical interview by their parents.
Yes.
Is it that the parent is going to be present while you're asking all of these questions?
It's not advisable to do that. Sometimes you gauge the child, especially if there is a parent-child relationship issue, and the child is likely not to want to speak. You can ask to leave, the parent to leave.
Okay, okay then.
Okay, so for older children, like teenagers, you try to understand, get involved with your lingo, understand what the street talk. So they have a lingo, they have a kind of language. Be familiar with that. So to establish rapport, ask children about their hobbies. Ask them about their hobbies. What do they do? What's your favorite subject in school to break the monotony and break the ice? So you ask about hobbies. Explain what you do. Who are you? What's your role? I'm a counselor. I work with children, and my task is to help you feel better. Sometimes I understand that it's okay if you don't want to talk now, but it's okay with me if you don't want to talk sometimes. That way, if you instill rapport and being honest, the child will feel much more comfortable. Any questions? Any questions?
No, Dr. Mac. Actually, Dr. Mac, there was a YouTube, one of the YouTube presentations that you had put on.
Yes.
Actually, I had a child interview going through with a counselor and a young boy, and she actually did this part where she asked him about, what is his favorite thing, and he actually seemed to have been in a foster home, and so she was there to try and find out what was going on with him. And so she was doing this very same thing, in trying to build rapport with him and asking him about his stuffed toys and, if she wants him to go and get it.
Where is it on the Moodle platform?
Yes, ma'am. That's where I saw it. One of the YouTube presentations that you did.
Yes, but which is it in week 4?
I think it might be a little earlier than week 4.
No, it's week 4.
Or it might have been week 4. It's week 4.
What's the name of it again? It may have been. How long is it?
Child play, individual, person-centered, and therapy. Child play. And that's the third video.
But how long is it?
I'm not quite sure. I can't remember.
But normally it's 6 minutes. 6 minutes.
How long?
The video is about 6 minutes or so.
Okay, Mr. Nami, can you find that on the client-centered approach and put it on, and we can watch it for and then we can have a discussion.
Can somebody? There's a lot of videos there. If somebody could tell me
it's week 4.
Week 4, the third video. Before the last video with the child.
That don't help me. I am not sure. Week 4. Tell me where in week 4.
We have 4 videos in week 4. The third video is what Michelle is talking about.
It's the last video in week 4. I didn't hear that. I'm sorry.
Week 4 have 4 videos. So the third one is what Michelle is referring to.
Grief and teenagers?
No, it's not that one. No, it's one with a lady.
The lady and the little child. Before the last one.
What's the name of it? Because
Dr. Mark, it's
those videos were intended.
Introduction to individual person-centered therapy under child play.
Okay.
Yes, Dr. Mark.
If somebody, I can't find it.
Right, while he's looking at, okay. All right, we won't. It's a pity. We won't because if we have some time, we can find. But let's just look at. Let's continue and wrapping up quickly. That basically, when you're considering the interview with children, you want to look at several points. Several points should guide you with this interview. One is looking at the referral. Why is the child being referred to you? Why is the child being referred? Look at the attitudes towards school and any problems at home. Attitude towards school, any problems at home. Look at peer and sibling relations. Very important. Peer and sibling relations is important in how the child will either internalize or externalize behaviors. Excuse me. Look at the relationship between parents and adults. Very important in the interview, in the assessment. It gives you an idea of how serious the family dynamics is. In teenagers, explore issues about sex, sexuality, let me repeat, sex, sexuality, drugs and alcohol use. In teenagers, about sex, sexuality, drugs and alcohol use. Now, why do I use the word sexuality? Anybody? Yes? Or they may have dalliances with girls. How would you handle that? So these are things. These are what?
Dr. McLeese, can I just to notify Kojo, I sent him the link.
Okay. Yes, because I would love that thing to be shown.
Yes,
give me a chance to get some water, get to quench my thirst. But I would love that thing to be shown to people that they can see it. Let me continue. So when you're doing the interview, make sure that the setting is appropriate. The setting, your setting in which you're going to do the interview with the parent and the child is appropriate. Playroom can be appropriate, or your office. The setting must put the child at ease. Setting should put the child at ease. You, the clinician, should move out from the desk as much as possible. Do not sit behind your desk. It's gonna create intimidation. Move from behind the desk. Sit side by side with the child or in front of the child. So move from your desk or from whatever you're sitting. Sit side by side with the child, even the teenager, or in front of, to lessen professional distance. Even for younger children, for a younger child, you may want to maybe sit on the floor. So the same level you are with the child will feel more comfortable and more able to rapport. So you want to do that to avoid. So you're at the same level with the child in terms of height and to avoid intimidation. Listen for secrets. If the child is having a rapport with you, listen for secrets. The child may talk about secrets that come out in a session. So if the child deals with secrets, how are you going to handle that secret? Are there any questions so far? Are there any questions, ladies and gentlemen?
None from me, Dr.
Any questions? Okay, let's continue with confidentiality with children quickly. I'm just taking some very important hints out of these notes.
Is this a heading, Dr. Mark?
Yes, another heading, please.
Okay.
Discussing confidentiality and add purpose with children.
Discussing?
You need to discussing confidentiality and purpose of treatment, I should say, with children. To clarify what I mean.
Purpose
of treatment? Yes, okay. With children. You need to explain to the child in very simple language the reasons for confidentiality. Okay? And I'll give you what you can listen, and you can take it down when you go back to the review in the Hangout. But you need to use, as I said before, you need to talk about the reasons why the child is there. You need to explain who you are and why they're coming to treatment. And so for both children and teenagers, you can say something like this. And again, you can take it down verbatim afterwards. Just listen. We are going to spend some time talking and doing things together so that I can get to know you and learn about what you like and don't like. This is a private talk. I won't tell your parents or teachers unless you tell me it's okay. The only thing I have to tell is if you said you're going to hurt yourself, someone else, or someone has hurt you. Do you understand? Is it clear, ladies and gentlemen? Yes.
There's a question.
Okay, good question. When a child talks about secrets, it's probably after you have had some rapport with the child. So depending what the secrets are, if the secrets are something that will continue to harm the child, you can say something like this, you know, Johnny has 5-year-old Johnny I'm talking about has, I know it seems very, very difficult. And so let's say if he's playing with the alligator, I know the alligator has some secrets to talk about. Remember we played a game about the little boy who has secrets? Well, you know, sometimes I can see now why it's making Johnny feel so sad. But I think right now what I want to do is to help Johnny feel better. So I remember we talked about that some things we have to tell mom and dad, that way that you can get some more help. I may have to do this because I need to do this to make you safe. You notice I didn't say anything about legal rights and all that? You notice I didn't say anything about that?
Yes, Dr. Mark.
You notice I didn't say anything about that. I'm making it very, very plain to the child. I didn't use any abstract language more than a teenager. I would say to the teenager, well, you know how our secrets are that we need to report it. And I have a legal right to do that. That's totally different. So you're paying attention to the child's developmental needs. At the same time, you are responsible ethically to report these things. So let me give an example. A couple years ago, when I was down there in Jamaica, I worked with a child who was supposedly the mother brought the child because she thought the child was molested. And saw the child for about 2 months and was in play with the child but did not see any evidence of that. And I was beginning to wonder if the child was actually abused. But one day I had a student with me. It was a Saturday, never forget it. It was about in the afternoon. The child was there with me in the play. and she asked for. She got some the people. She got some. She asked for some water, so she got water. She fills the water a container with water, and she started asking for some soap, and I gave her the soap. She asked for a rag, and she put some people in, and she was scrubbing. She scrubbed a little a figure in the water. She was doing that for 20 minutes, literally. So I watched and watched and watched, and says, there now. And so she said, see, this is what happened. So I said to her, seems that let's say little Marie has a problem. She's in the water, and is she feeling dirty? Is she what's happening to her? And she said, I want them to see what happened. So so in other words, you're seeing in the play, you're seeing the results of, so she's now feeling more safer to reveal what has happened to her after some time. So even 2 months, she was able to talk about the fact that something traumatic happened to her. And so we were able to work with it. So when we do play, touch and play tomorrow, I'll be able to deal with some issues about that. Sometimes with young children, you may not be able to understand, they may not be able to articulate secrets. So one way to do that, to answer the question, is that you can also use art. You know, there are therapeutic stories that deal with abuse or trauma that the child can feel more aligned with, and the child can draw, the child can color, but talking about it may not be the best option. But like I told you, if the child talks about something that has a direct bearing on the fact of reporting something to the child, you need to report it. But you explain to her, the child, in simple language, that it needs to be reported to the parents, for her not to feel hurt again, or to feel safe again, or to feel. Hello?
Yes, Dr. Mark.
Is that clear? Okay.
Yes, Dr. Mark.
Yeah. So there are ways in which you can get information, but like I said, young children, there are therapeutic stories, there are therapeutic toys that can evoke that kind of memory. You need to, those things you need to buy. They're not American, but there are ways you can get the activity. There's an activity book I gave on activities I'd given students. It's on I believe week 4 about activities for children and adolescents. Download that. That's it. That's my gift to you. Okay. Oh, incidentally, just remembered, I have access to the child adolescent. I mean, not child adolescent. I have access to the child treatment planner 2014 last year, and I may get a copy of a PDF copy of it downloaded. So if I get it from here, I'll send it to you, so you don't have to buy the child planner.
Thank you, Dr. Mark.
Beg your pardon?
Thank you, Dr. Mark.
Yeah, I have that, but I have a teenager. I just realized I have it among my many books. It's here, but unfortunately, it's a hard copy. I will have to find out if it's downloadable. But I have a copy of the adolescent treatment plan. I didn't remember I had it.
One quick question, Dr. Mack. In the
Yes.
2014 treatment planner, it
Yes.
speaks to, in the diagnosis section, it speaks to ICD code 9 or
Yes.
DSM-4 as well
No,
as
the
ICD
treatment
code
plan
10.
I have is DSM. The one I have is DSM-5 updates, not 4.
As do
This
I,
is the most
Dr.
current not on the market in North America.
As do I. And I'm just telling you what I'm seeing in there.
Okay.
It says it speaks about Axis 1. Sorry, that's what I should say. It speaks about Axis 1, but with DSM-5 does not speak about Axis at all. So I just wondered if
there's no axis. It's just a dimensional. So there's no axis anymore. You speak of a dimension of diagnosis in a dimension.
Dr. Mark, just let me tell you what I'm saying. In the book, the Child Psychotherapy Treatment Planner, the one that includes the DSM-5 updates, the 5th edition, 2014. When you look at the diagnosis section, it says, because the one I was looking at, it has the Axis 1, 2, and 3, and it has the ICD-10. Now, for the treatment planner that you want us to do, we must not at all look at the DSM-4 ICD code. Just focus on 5.
5 is what is in sync right now. No, I don't expect you to do DSM-4. No. I'm trying to get that DSM-4. I'm trying to get it down that you can have a copy of it. I'm going to have to bring my laptop to the library tomorrow to have them download it. I was checking. They have it online. And I will try and get it, but you're not to use the DSM-4. It's no longer legal to do that.
I know, Dr. But from time to time, it kind of pops up here and there. So I just wanted to.
Yes, they're now updating. That's why I didn't want to buy any books, because a lot of them are being updated. It takes time.
The book I'm looking in is the correct updated book. That's what I'm saying. What I'm saying. The one that I have is the 2014. So that's why I was just asking the question based on what I saw in the book.
Yes. You use the DSM-5 nomenclature.
Okay.
Do not use DSM-4. I will not accept that. Use DSM-5. That's why you need to bring your DSM-5 to the exam, or use it wherever you use it. And but you need to. But as I said before, they have Axis. They have the Axis 1. They have the 2. But you look at other factors like contextual factors, cultural factors for the child, etc. Okay. All right. Let me continue because I don't want to go off the deep end with this. So. Just some quick things about, I talked about confidential with children. Like I said before, you let them know. Somebody's asking a question, by the way. How would you inform the parents that the child was molested? If you're talking about reference, the fact, two ways. One, if the parent is suspect that the child was and wants to have some empirical evidence, that can be done through the play. However, let's say this were to go to court. You can't really prove it unless you have the child physically examined and determine if that occurred. 2, if in case that you discover that the child was molested, you need to tell the parents, or the child tells you or shows some way. You need to let the parents know and find out what's going on. And you have to report it. May I repeat? You must report it. You have to report it. You absolutely must report it.
So, Dr. Mark, what if the molester is probably one of the parents or an extended family member who lives in the home? How do you deal with that situation?
Child must be reported for the child to be removed out of the home.
But you still say something to the parent?
Yes. That you're going to report, that you're legally mandated to report it. Let me give you an example. There was a child came to me, was asked, some parent asked me to see a child. She came from a certain high school in on Constant Spring Road. I won't call the name of it. You should probably know what it is, if I remember. And she was about to be kicked out of school. She came in a uniform. Mother brought her there because she was about to be expelled. And I don't remember, but I remember, I'm trying to remember the details of what, but I remember stepping out to get something, retrieve something, get some pen or paper or whatever. And I said, okay, I'll just see you for a little while. And I'm talking. And as I was coming back, I heard some struggle in the room. And I heard like somebody was hitting someone. So I burst the door open and I heard the child crying. She was and I said, did you just hit this child? Did I hear what you just heard? I said, if you hit her again, I'm going to report you. Why did you hit her? Why did you hit her? I said, if you hit her again, I'm going to report it. Am I making myself clear to you, ma'am? So these are the things you have to guard against. People will want to hit children. So no, you need to report it. However tried, you need to protect yourself. Because they're not going to, children need to be protected. I mean, like I said, I can't remember what she did, but as I left, as her back was turned, she was hitting the child. She was frustrated. I remember now, she wanted the child to be assessed because she wasn't doing very well in school. And I think I remember telling her what my fee was for assessing the child. She was not happy because she had to spend money. She didn't have the money. And I went out to get something, and she was hitting the child and said, and I heard her, look what you're causing me. Money this, you know. I said, ma'am, if you hit this child again, I'm going to report you. Do not do it again. And I was very firm. I said, am I making myself clear to you, ma'am? All right. Any questions? Any questions you have? Any other questions? All right. Just quickly. Dealing with lying. Children lie, right? Yes. Yes, I jumped the gun a bit, but I'm gonna deal with now dealing with lying. I'm just jumping around the notes because just some key things I want to talk about. You can read it. If it's not, somebody said that it's not up. Do you not see this notes on I know it's there. It's there. The notes on, okay, but dealing with lying. There's no way to find why children lie. But just to know that children lie for several reasons. One, they feel threatened. So they feel threatened, there's a fear of being punished. Afraid of what they say may get them into trouble. Fear disapproval from the clinician or adult. They may want to impress the interviewer or the clinician. They may want to gain a desired outcome or advantage. For which one? They may want to gain a desired outcome or advantage. Another thing I want to talk about, and that's a line, just another, is that dealing with boundary issues with children and teenagers. Dealing with boundary issues. So So children, for example, may so in the interview, the child, as a child gets to know the child may be curious about who you are, and so the child may want to ask you personal questions. Are you married? It's a teenager. Are you married? Do you have any children? How would you deal with that? Okay, how would you handle that?
Dr. Mark, I would tell them to mind their own business.
Is that the way you like? Is that the way you tell them?
No, Dr. Mark, I'm just joking.
I'd probably ask them, Dr. Mark, why would you ask that question or something of that nature?
Be careful how you'd ask that though. Because
okay.
it would ensure that you are saying that I'm not approachable.
Or I mean, you could ask a question, but ask it in a way that would make it approachable, like maybe saying, is there a reason why you're asking that question or something like that?
Well, you could say it by saying, there are a lot of things we could talk to that you could get to know me as we go about treatment. But right now the treatment is about you. So how can we focus about that? And probably who knows if when we have some time, we can talk about how my work will be able to help you in terms of your family issues. That's where you're deflecting, but you're being you're bringing them back to that focus on them.
Okay.
What would you share? Ask him. No. Could you put it there, please? I can't see it.
I'll put it in.
Okay, but then what would you share? You have to be careful about boundary issues. What would you share? How would that help them in the relationship? Not saying you can't do it, but how would that help the child? How would you put it? In what way would you put it? How would you say that?
Good night, Dr.
You say the way you said it now? Yes.
Good night, Dr.
Yes,
Mark.
Yes, Miss Christie. You're saying something?
Yes. I believe in sharing, as Robert said, you want to build the child's confidence in you. Yes. You want to develop a trust between the both of you. So I agree that we could share with the child, tell the child if you're married. I mean, as long as the question is not too personal, you can have a conversation, and I do believe you need to develop a rapport to gain the child's trust.
Yes. I mean, yes, but you don't want to where you do that and you open up a whole can of worms. Because they may ask you more questions and more questions. So you want to. So you do. Yes.
The thing about that, Dr. Ma, that I'm thinking is that the reason why I would ask why, in a way, of course, not to sound unapproachable or so, why the child could be asking that question. There, in my mind, there has to be a reason why the child would particularly ask that question. And because of how my brain works, I would want to know, kind of go behind that question. So I guess I'd have to find a way to find out. Not that I wouldn't say it, but I would want to find out why would you want to ask that question.
How would that help the child therapeutically?
I don't know. We would continue going through the session and maybe something would jump out. I really don't know at this point. But I'm just saying that if they ask some questions that they really, somebody else might not ask, there must be a reason. Something might be going on in their thought processes that would cause them to ask that question. That's just how.
Or one way is that sometimes they want to know. Asking you the questions may mean that they're trying to make it's almost like a projection or identification with you. If they see you as a stable object or see you as a stable person, that they may want to identify with.
Right. So the point is that they really are asking a question. Hold on, Helogene. The point is that they're really asking a question for a particular reason, and you just underscore that.
Dr. Mark? Yes, my thing though is in treating children or adolescents, for example. I'm just wondering though, let us say, for example, that you are a single person and you don't have any children. Now, they ask you to have any children, and you answer, no, I don't. That may come across, they may take that to feel that, well, if this counselor doesn't have any children, how is she going to understand me? So I think maybe you need to probably be careful because you don't know how that information can impact on the child. Similarly, I mean, they're coming. Let's say they have two parents at home, and they're seeing their parents' marriage and so forth, and they ask you, "Are you married?" And then you say, "No, you're not." Then again, that can maybe come across as, "Well, if you are not married, how can you understand what my parents are going through and so forth?" So I think
it's best that you don't reveal. Yes. I tend to see where you're going with that. I think you need to there's a boundary, and that you know it's really about the child, and you know you have the skill, even though you don't necessarily have to have children or get married or be married to be able to understand how to work with a child in the home. That is true. That is true too. Okay, so we are trying to use this to get some very important. You can create your own response, bearing in mind that you need to be there needs to be some professional distance. You don't want to get too chummy with the child because you will lose objectivity. Your goal is objectivity with the family, the parents, because the child is a client. The parent is really the client, and the child is there. These are clients. These are not your friends.
Dr. Mark?
All right. Yes.
Dr. Mark? For me, I had a situation like that. It was an adolescent, and she asked if I was married, and I said yes. And it was from that conversation she was able to share her views on what was happening in her family and why she doesn't believe in marriage. It can go both ways about sharing and not sharing.
It can go both ways, but you have to use in the moment. No, and I can only give you some rule of thumb how to deal with that. But generally, just basically you are trying, it's about the client, and you want to be as objective as you can, and at the same time being professionally distant. Not necessarily that you don't consider the client, but you need to have boundaries. Am I making myself very clear?
Yes, Dr. Mark.
Dr. Mark.
All right. I think we're going to wrap up with the interview. Somebody was asking if the child interview is on the platform. I believe it is. It's there. And I believe the mental status exam is there also. I will look again and send it to Mr. Neme for him to put it online. But do we have that video up that I could get a wine break or a water break?
Okay, I'm gonna try again to get it on YouTube in here. I'll copy it to the students on YouTube themselves. Hopefully they'll know to manipulate two YouTubes. And
you haven't loaded it yet?
No, I have it on Moodle. I'll just copy over the link.
All right, let me know when you start. That I can at least start the treatment plan start going in that right now.
But let me just. You're gonna start now?
What do you want me to do?
I could try to run this.
I'm anxious about getting this thing out of the ground right now.
You want me to run the video?
Yes, go ahead.
Is it the video? There's a video that says.
How long is it?
The video that says it's 7 minutes, but it says play therapy. It's about play therapy. Is that the one, Michelle?
Hello?
I don't think that's the one.
Misha, that's the one with the man and the boy, where they were showing him.
No, the one that I was looking at was a lady and a little boy in a wheelchair. That's not the one. That's what I'm thinking. It was a little earlier than 4.
Then why would it be week 2? Why would
Dr. Max, sometimes some of the information that you have, it's a little bit high. It comes before the section that you're at. So sometimes that's what we find happening. But I remember that it wasn't week 4. It was a lady and a little boy in a wheelchair.
All right. Well, I tell you what. Let's go to treatment. I'm very anxious about this. I don't want this tonight to pass.
We can always go on it and watch it, Dr. Mack. It's okay.
Right. Ladies and gentlemen, we can watch it. Mr. Name, it's okay. You can watch it off the class. We don't have the time right now. Time is up against us. So I need to do this. So, ladies and gentlemen, let's switch topics for a little bit. If you would permit me 1 moment, I need to get something to drink. I'm a bit thirsty. Would you mind if I get a drink?
Dr. Mark, that's fine.
Good.
Give me a moment, please.
No problem.
What are you saying?
Good night, guys.
Good night, Marlene.
Okay.
Hi, Marlene. How are you?
Hi, how are you?
I'm good, thank you. I was trying to call you, Michelle, but I see you didn't respond. Thank you, Victor.
Get some can you become a
Probably couldn't respond, Marlene, because I was in the chat or doing something. I'm not quite sure.
Okay.
Sorry about that.
It's all right.
We'll talk after. We'll talk after. Problem. Okay. You're not tired? Because I know you had a long
night. Not really. Not really. I've been trying to do something to avoid the tiredness.
Okay. Okay, great.
Why, I tell you, after today, I'll surely do that. If it does work. If I can go until midnight tonight, I'll let you know.
Hello? Yes? Yes,
okay.
Yes, I do.
We're back. Thank you.
No, yeah, that too. Like a friend.
Going back to that Monday night's notes, I just realized we're supposed to have talking about, we hadn't finished the ethical considerations, but what I'm going to do is when I'm done with this, I'll also send these notes to you. How about that?
That's fine,
Is that okay?
Mark. That's fine.
That's okay, Dr. Mark.
But let me just go through and explain some of the things about treatment planning.
Okay.
Mr. Naomi, I sent some PDF files on the treatment plan. Could you prepare to load them, please? Could you load there's a TCC clinical child intake on the Moodle. Could you upload it, please?
It's on the top part of the.
It's on the top.
Okay.
Upload both. Yes, prepare to upload both. Let's continue, ladies and gentlemen. This now is treatment planning and treatment plans. Now, what is treatment planning? Diagnosis, as I said, leads to case conceptualization. And case conceptualization leads to treatment planning. It is a roadmap that a client must follow through treatment. It's a roadmap. Two, it is focused directly on the presenting complaints of the patient or client. It is focused directly on the patient's presenting complaint that the patient would bring into the interview, the clinical interview. Three, it's a part, the treatment plan is a part, or I should say forms a part of what is known as the problem list or target behaviors.
Repeat that, please.
It forms a part of what is known as the problem list or target behaviors. And these are normally from the clinical interview. Get this from the interview with the child, parent, etc.
Is there an example of what that would look like, Dr. Mark?
Sorry?
Is there an example of what the target behavior would be?
Johnny, who is 7 years old, is presenting his... Tell me what brings you here, ma'am. How can I help you? Well, I have a son, ma'am, and he's acting up. He's 7 years old, and he has been acting up for 2 weeks, and he's hyperactive, he can't sleep very well, he's not doing well at school, he's not paying attention, and he's not learning. Those are target problems.
Oh, okay.
Is it clear?
Very clear.
Okay. 4. The target list or target behaviors come at the end of the diagnostic summary. Let me repeat. The target list or target problems come at the end of the diagnostic summary. And this list, the problem list, must take into account the problem list. Yes? Comes at the end of the diagnostic summary. The list, the problem list, takes into account psychological, emotional, and behavioral problems. That are relevant to the child's issues. It's relevant to the child's issues and also looks at the child's strengths. When I say child, I mean teenager also, strengths and weaknesses.
Dr. Mark. All right, seeing that we're looking at the treatment plan. Yes. So you're saying that when you're writing up your treatment plan, let's say, for example, that the client, you have diagnosed the client as having anorexia nervosa. So after you say that, okay, this client has been, or this client has anorexia nervosa, then at the end of that summary, you're going to be saying all the target behaviors and whatever that is related to the anorexia would come after that.
Come again. I had a moment of lack of concentration.
Okay. What I'm saying is, you said in point number 4 that the target list of behaviors comes at the end of the diagnostic summary. So I'm saying, so you're writing your treatment plan and you would say, okay, this person has been diagnosed with anorexia nervosa. And then after that, you're going to be listing all of those problem behaviors that would be connected to the diagnosis, basically listing.
Well, what I mean, okay, good observation. What I mean is that in a treatment plan, it's going to really look at target behaviors from the clinical interview. So what you're doing is that you're taking what is the crux of the problem, and you're going to create a treatment plan based upon those problems that the child that is being reported by the parent or the child. Or more so the parent, because when children come, it's the parent saying this is what's happening. The child sometimes doesn't even know why they act up, but this is what the parent is saying. What a diagnostic summary is basically what you're doing is that it's basically your case conceptualization. This seems to be an 8-year-old. Johnny is a 11-year-old. Black Jamaican male who came to the counseling center because he was having difficulty with anxiety, poor sleep, night terrors due to his parents' divorce. That's the diagnostic summary.
Okay.
Okay, Dr. Max. So, okay, because when you say diagnostic, it's almost as if you would be, it's almost as if
you're already case conceptualizing.
Okay.
So, in other words, you're saying what the client's problems are, where they came from, and what is going to be done about them. So it appears that Johnny will be suited for some family approaches, or will be suited for play therapy, or will be suited for transactional analysis. So that's what you're basically saying. There are types of treatment plannings which I don't at this point don't want to elaborate on too much more than talk about. Again, if I have time, I'll go back to that, but I want to go through the notes. There are 4 components. Seligman, 1993. 4 components of a treatment plan. There are 4 components of a treatment plan. 4 components. 1 is the clinician must behaviorally define the problems to be addressed. So most problems are behaviorally defined. What you have, there are behaviors that need to be addressed. So they are behaviorally defined. And these behaviors are the focus of treatment in the form of goals and objectives. These behaviors are the focus of treatment in the form of goals and objectives. Two, the goals are selected. The goals are selected based upon the target problems to be addressed. So they are based primarily on the client's immediate needs. You need to get the client better. That's basically what you're doing. You want to get the client better. So you're now taking the problems and you're going to create measurable goals based upon the symptom severity that symptom. So in case of Johnny Walker, let's look at that case. Johnny Walker had what? You remember the case?
Yes, Dr.
Johnny Walker had what? He had anxiety. What was happening with Johnny Walker?
Oh.
Do you have the case in front of you? Do you have the case in front of you?
Okay. All right. Okay.
Do you have the case in front of you, ladies and gentlemen? What was the problem with Johnny Walker? I don't have it in front of me right now, so I'm asking. What was the problem with Johnny Walker? Give me the target problems. What were the target behaviors of Johnny Walker? Okay. That's a target problem. You're right. So that is also part of the complaint. So you're going to put that into a behavioral goal. What else? So worries is another is worry a target behavior? Is worry a target behavior? But is it a target behavior to be treated by a treatment plan?
I would say yes, Dr. Mark. I would say yes.
Mm-hmm. What else? Okay, so restlessness and anxiety are another treatment target behavior. Am I correct? Anything else? Okay. So just look at the target, pick up the target behaviors from the veneer. Pick it up from the presenting complaints, and we're going to start looking at a treatment plan. Anything else, anybody else? I'm only hearing Miss Okay, so headaches is another behavior. What else? Anybody else? I see only one person telling me these. Anybody else?
Well,
what have you used to say?
He had excessive anxiety and he is always worried, especially since his mother met in the accident.
Mm-hmm.
And
yes.
He was restless, and sometimes he had he felt tense and had,
yes.
as Elogene said, night terrors, and he would wet his bed.
Okay. Any other symptom?
YouTube made a thing there. I pasted it.
Let me get to it.
Dr.
Yes.
Mark?
Go ahead.
I'm not too sure where this would fall, whether sign or symptom, but the fact that he blamed himself for his parents' divorce. At the end of the case, it indicated that he was blaming his failure in school as the cause for his parents' divorce. I don't know what that would fall under.
Is that a target behavior? That's the question to ask yourself. Is it a target behavior? Is it? How can you measure that? Okay. So what we're doing is that we are looking at target behaviors that is we're going to be using to formulate a treatment plan. We can't do that until we know what is it that we're going to measure. So I'm on the fact of 4 steps or 4 components of a treatment plan. So we are looking at goals that are selected based upon a target problem, and you look at that in terms of the client's needs and the severity of symptoms. So Also, it depends on the client's motivation for change. Because in a treatment plan, the client must be involved with it. Treatment plan involves the client. It's never the therapist who, or the clinician who determines, okay, this is what I'm gonna treat. The client must be in agreement with how you write or frame the treatment plan. Is that clear?
Yes, Dr. Mark.
3. You determine the type of treatment to be used in relation to the client's personality dynamics and the client's particular problems. You determine, so every client is different. There is no, you can have 10 clients, you have 10 different treatment plans, totally different.
Say that again, Dr. Matt. Determine the type of treatment to be used in relation to the
client's personality dynamics. 4. The treatment plan must reflect how change is going to be measured and how the behavioral outcomes are accomplished. Treatment plans deal with change for the better, restoration, resolution, and how behavioral outcomes will be measured. How are you going to accomplish that? Treatment plans determine how change will be accomplished, which is based upon resolution of the problem, restoration, and how the behavioral outcomes will be accomplished.
The behavioral what?
Sorry?
And how the
behavioral outcomes will be accomplished. All right, before we go on, I know Mr. Name put up the, this is a copy of a child intake. Could you modify, Mr. Name? We're not getting it. Go up to the top for it, please. Could you? Yes. This is a copy of, for everybody, the biopsychosocial history of a child that's used at the counseling center when I was there and I developed this. Okay? This is what's used. Now notice client identification is important because when you are case formulating, you must use the client identification. Client is a 9-year-old black child or 18-year-old child's name, female, age, birth date. Sexual orientation is important. Better believe it.
So they would know their sexual orientation at 6, Dr. Ma?
No. I'm talking about for teenagers.
Okay.
But sometimes children know that from they're young, but I wouldn't base much on that. I'm talking about teenagers.
Okay, Dr.
Could you go further, Mr. Nami? Let us go through it quickly, please. Note here that it's religious denomination is important. Sometimes people are religious. If they're not, then you don't. But you ask. The presenting problems. Now, note, for example, the presenting problem is a chief complaint. Are there any problems? What is it? Tell me what the problem is. How can I help you? You document what the problem is here. This is where you get the target behaviors for the treatment plan. Is it very clear to you?
Yes, Dr. Mark. Okay,
continue, Mr. Name. Oops, went a bit far now. I wonder what this. Okay, main area where the child has problems. So you are now quantifying exactly what are the where the child is having difficulties. Is it schoolmates, neighbors, friends, conflict with family, personal or inner dynamics? This is on the Moodle platform, just going through quickly. This is what you will determine how you're going to work. Are you going to work with family? Are you going to work with, understand the child, to deal with the child's peers? Are there any internalizing problems, sexual problems in terms of teenagers? Are there any issues with fear of authority? Are there any problems? So these are things for children. How long? Duration of presenting problems. Is it 1 to 7 days, 6 weeks to 6 months, over a year, 6 months to a year? Have you seen anybody about the child's problems? To whom you talk to? Medical history. You get a sense of what the child's history is. And why do we need medical history, ladies and gentlemen? Why do we need medical history? And you what?
Dr. Mark?
I was about to give you a glass of wine. See, I'm sipping some wine here.
I'm also thinking
What's that?
I'm thinking, Dr. Mark, that there are some diagnosis in the DSM-5 that it will the symptoms that the child is displaying could be as a result of a medical condition. So
Very
you also
brilliant.
need to,
very good.
Yeah, you have to rule out the medical issues.
Very good. Very good. Continue, Mr. Nyame. Okay, so stop it there. So we're looking then now at, you're looking at risk factors. You're identifying risk factors, Rotter's indicators in the intake. You're getting information. Continue. Okay. You're looking then at any pain with the child. You have to ask about pain. Does the child have any pain? Could be the child's anger or aggression or irritability is causing because of pain. Family social history. Does the child live with somebody? Who does the child live with? Are the parents married? Are they divorced? Is it a single home? Continue, Mr. Nyame. Siblings, no sibling rivalry, number of children, marital history. Okay, one thing you need to ask a child or a teenager, you'll get, this is more projective in nature, but if you were to be granted 3 wishes about your family, what would you wish for? You'll be surprised what you get. If you were to be granted 3 wishes about your family, what would you wish for? This is very important in getting that information. You're getting in terms of the child's fantasy life about family, cognitive processes, what's happening there with family. Very important. Continue. Document any abuse or neglect history, family developmental history, psychiatric problems, school placement. Why do we need school placements? Why do we need school placement? Yes, but why do we really need school placement? What else do we need for? What else?
It can also help to determine how the child is performing in school.
Also, Dr.
To determine what?
Also to see if it's also serving as a perpetuating factor to what is happening to the child.
I'm sorry?
So as it relates to the perpetuating factors, to see if that is also a part of what is, helping to, increase the problem that the child is going through or whatever.
Yes. Okay.
Also, Dr. Mark, sometimes school problems can also lead to a lot of behavioral problems.
Yes.
The child is not doing well in school, then how they internalize or externalize, as you always say, will come out with behavioral difficulties.
Okay. Someone is asking about, I think Roina was asking about, is this form used in all cases? This is a child form. It's used only for teenagers and children, not for adults. There's a special adult form. You will have these things asked in an adult. And the medical history, because biological factors can contribute to child psychopathology. Okay. I think that was done several times. So basically what you're getting then is a sense of all the various vectors of the child's life you need to assess. Do you see that? Do you understand? Is it clear to you now?
Yes, Dr. Ma.
Yes, it is clear.
Okay, Miss, you can continue, Mr. Nyame. Let's finish up the intake. Why is finances important in assessing a child?
Rotors indicators.
Good. Continue. Legal problems. Why? Because you may have what? A child with a pending conduct disorder, right?
Yes, Dr. Mark.
So you need to look also at baseline function, meaning how is a child? Is the child eating, sleeping? Is he doing homework? Is he able to help with the family? Is he eating? So if you're looking at eating disorders, this is also important. Continue. So all of this is looking at baseline functioning. There is also a substance abuse history for teenagers that they treat with abuse drugs. You may need to also list that. Continue. So you take a substance abuse history of what the child is taking, or is there a family history of substances? And of course, the substance abuse profile. And of course, the mental status exam for children. So these are what you'll ask. Okay, you can stop. For example, you can stop, Mr. Name. For a parent, you may want to, that's for you to observe. You observe. Child came in appropriately groomed, made good eye contact with a clinician. Or grooming was disheveled, child appeared to be dirty, came with a dirty t-shirt and pants. That's appearance. Flow of thought. Speech was spontaneous without any tangentiality. There were no flight of ideas suggesting any mania. Is that clear? Hello?
Yes, Dr. Mark.
Hello?
Yes,
Dr. Mark. Just a moment. Orientation. Yes, this relates to the person's, are they aware of their environment? Child was able to, what's your name, young man? Tell me what your name is. Where are you now? Where did mom and dad take you? This is known as orientation sensorium. This deals with whether or not a child is delirious. They are able to know where they are, who they are. So all these relate to mental status. Homicidal ideations, you ask a child, and how I ask in terms of ideation, do you ever sometimes wish if you were to lie down, you wish you were dead? And that's differently with an adult. Do you have suicidal ideations? So this is what you ask. So note in terms of mood, is the child anxious? Is the child depressed? Is there dysphoria? Is it normal mood?
Dr. Ma, one question, please. What is confabulation?
Confabulation is when somebody makes up stories in order to cover up a gap. That mostly deal with people who have either a head injury or they are having some serious memory, like people with Alzheimer's disease or so forth.
Okay.
So, but this is basically capturing the essence of the case formulation and the clinical interview. You will ask these questions. Am I clear? Ladies and gentlemen, am I clear?
Yes, Dr. Mark. Yes, you are.
Will you be sending this to us, Dr. Mark? Or do we have it already?
It's on the top of Moodle.
Ladies and gentlemen, may I underscore, it's on Moodle.
It's on Moodle, okay.
Yes. Yes. Okay. Continue, Mr. Namek. Thank you. Continue and let's wrap up the intake. Continue. So all this is a part of the mental status exam. Now, I should say this, that in children, neuropsych profiling is important because Rotter's indicators, risk factors, did the child have any blackouts, head injuries, seizures, brain fevers, hydrocephalus or water in the brain, cerebral palsy, difficulty concentrating. This is important, and this of course is when you have the 5 axes. So this is the diagnostic formulation. The 5 axes from the DSM TR before. Continue. And of course, you write the summary. You summarize the summary.
Dr. Mack, Dr. Mack, before you move from the DSM-4, you know, we have been going through this, and somehow I don't think we have ever stopped to really say how we use the DSM-5 to diagnose now, since we are no longer using the axis 1, 2, 3, 4, and 5.
You had that class last year. I mean, wherever.
Not with you, though, Dr. It wasn't with you. So I'm just wondering if it is that the way that we were taught in another class, if that is acceptable to you.
I'm not certain what you mean.
What I mean is that you're not going to use the axes. What I'm saying is that you're not going to be using the axes. But 1, 2, and 3, I believe, is collapsed into one. So you talk about the clinical disorder, you talk about the personality disorder, and then you talk about the stressors, and you don't have the gap. So you're basically just having two sections that you're going to be putting in the diagnosis. So instead of the 1, 2, 3, 4, 5, you're actually having 2. So I'm saying
no, but I recall 10 people. And no, go ahead, finish your sentence.
So I'm saying this based on what we had done last class, especially for the examination, where you had asked us to do that, and that was particularly that was the format that I followed based on what I was taught in another class.
Yes, but
I'm asking you if that is the format that you
no, I'm not expecting that. No, what I expect is that you follow the DSM-5. The DSM-5 in the first couple, it outlines exactly how you need to do that. What I want in this class, as I asked you, is that you'll be asked about a diagnosis, you'll be asked about one diagnosis, you'll be asked about Rotter's indicators, any risk factors, you'll be asked about then determining a basic diagnostic formulation. You do a treatment plan and a treatment approach, that's all.
All right, and all of what you just
class.
Okay, fine. And all of what you just said a while ago, those are specific questions that you'll be asking. Or is it that we need to remember that that is the order that we need to do the
No, I will be asking those specific questions.
Okay then, Dr. Mack. Thank you so much.
Okay. All right. So let us so thank you for this. Let's get back to the treatment plan. Just want to show you what the intake yes. Yes. A treatment plan, okay, a treatment intervention is a specific selected strategy to solve the problems, and it is normally manifested in a treatment plan. Treatment plan is a comprehensive document where you have certain target goals and objectives, and those goals need to be measured. An object need to be measured, and they are measured by the problems that you'll outline usually from the client. Let's go through that, and then we won't have to ask those questions. All right. So let's put this away. Mr. Nyamik, the treatment plan I sent to you, could you put it up, please? And we go back to. Is he there?
Yes, but I'll have to go back to the folder now.
Yes, I know. I'm sorry. I know. I know I'm straining you, but let's go back to the treatment plan, ladies and gentlemen, and then we want the questions will be more clearer. So let's continue. Now you don't have to take this. I'm going to send you the notes, so you don't have to take this part of it, but some other part you need to take. For this one, I'm going to read. If you have any questions, stop me and I will answer them. Just listen. Treatment is based on duration and outcome. It is once a week or every 2 weeks. Treatment involves types of interventions such as group, individual, family, or medication management. The focus of treatment should involve specific problems from presenting complaints. Johnny has anxiety. Johnny is wetting the bed. Those are target behaviors are problems. The particular goals and objectives of each treatment should be specified as part of the treatment plan. So, so in your treatment, you're going to note the more serious problems in order of priority. I'll stop there. Are there any questions? Just explaining what the components of the treatment plan is, what it really is.
Dr. Mark.
Mm-hmm.
I have a little issue because, for example, if one particular behavior is being manifested because of an underlying issue,
yes,
you still have to treat both the underlying issue and the behavior as well. For
us, let me underlying issue is. That's all right.
For example,
go ahead.
In the case of Johnny, the bedwetting,
Yes.
We're thinking that the bedwetting is really as a result of the underlying things that are happening to him. But
yes.
I'm sort of getting the idea that we must still target the bedwetting as a problem.
You still have to target it because it's a problem. Anything that is a problem to the child, you must target it as a behavioral goal with an objective. So all the things you talked about, including bedwetting, is a problem for the child. Even though the child doesn't know, it's a manifestation of something, an underlying problem. It is still a problem that you need to tackle. How are you going to stop the child from getting wet in the bed all the time? How do you treat enuresis? You treat it with medications, or you treat it with the bell and pad, or they get the child. You have it where the child knows that they have to get up. So let's go through how to develop a problemness. And for now, you can take some notes. How to develop a problemness. That is from the presenting complaints. And we'll wait for Mr. Nami to put up the treatment. Oh, it's up. All right, let's continue. So one is that a treatment plan generally must be measurable. When you look at a treatment plan, it must be measurable. You must be able to measure whatever it is the problems are. The problems must be so measurable that the child understands or the parent understands, and you know that once you write them, a goal, an objective, it will be resolved in 6 months or a year. That's the aim, that people will get better. So it must contain problems, a set of problems and solutions that must be measured. It's measurable and contain a set of problems and solutions. Rather, it's measurable and must contain a set of problems and solutions. The problems must be specific. Number two, problems must be specific. Example, Johnny is anxious. Johnny has a headache. Those are problems. That's specific, isn't it? Three, problems must be evidenced by signs that you can see. Signs that you can see, symptoms, what the patient tells you. That's 3. Problems, a problem must indicate any emotional, physical, or behavioral evidence. It must have a specific physical, emotional, or behavioral evidence that the problem is existing. So if you say the problem, Johnny is anxious. We're going back to the case. Johnny is anxious. Is that a specific emotional problem? Unmute your mics, yes or no?
Yes.
Okay.
Yes.
So you know the problem exists, yes or no?
Yes.
How do you know the problem exists, ladies and gentlemen? Because you see.
You can see it, you can observe.
Okay. So you know the problem exists. So in the case of Johnny Walker, just giving you the example, I'm going to give you the example. Problem is for Johnny Walker, headaches, anxiety, headaches, anxiety, night terrors, poor sleep. Problem list, headaches, anxiety, night terrors, poor sleep. Those are going to be on the treatment plan that you're going to be solving. Yes, unmute your mic, is it clear?
Yes, Dr. Mark.
Ladies and gentlemen, is it clear?
I'm clear.
Okay.
Yeah.
Goal of the problem list. So let's go to the treatment plan now before we go to that. So, you can go, Mr. Nyame. So on the master treatment plan, also that I created, it's at the counseling center. You need to determine what are the immediate focus of treatment. So you check. So if you were to go to Johnny, if you have the case in front of you, tell me how you check there. What would you check in terms of immediate focus of treatment? What would you check?
Dr. Mark, it will be the level in terms of if it's anxiety level, if it is mild, moderate, or severe.
I'm talking about immediate focus of treatment, as in the treatment plan as in front of you. What are you going to check on the treatment plan if you're going to be providing a goal, an objective for? Tell me from the case, what are you going to check on that, on this?
One could be process family of origin issues.
Okay, and that involves what? Divorce?
Divorce, right? And the marital discord. Yes, Dr.
That's good. And what else would you check for Johnny? What are Johnny's problems?
He's having some amount
separation
of
attachment issues, behavior problems, correct? What else?
Separation. He doesn't have any separation issues, Dr. Man.
No.
Well, does he have any separation issues?
No, Dr. Man.
Does he have any academic problems?
He's securely attached. What's that, Dr. Mac? What's that, Dr. Mac?
Does he have any behavioral problems? Academic problems, I meant.
Yes, he has academic problems.
So you check that. You'll check that.
So that would be under what? Behavior problems?
No. The immediate focus of treatment, there are a number of them there.
No. I understand what you're saying, Dr. Mac. But you said separation attachment, so you said there was not any. You mentioned behavioral problems, and then you were asking if his problems in school, if that would be an issue. So we are saying yes. So we're
on the
academic problems has its own checklist.
Yeah, but you'll make what you're doing is that you're making generalizations about the problems on the treatment plan.
But check it where though, Dr. Matt. There's nothing here that speaks to his his.
There's the academic problem section.
Okay. There are academic problems. You check it. That's just what is provided. You check it.
Academic. Okay, yes, academic. Okay, I didn't see. That's all. Thanks.
Okay, so there are a number of things there that you check for the child. So other, you check anxiety, all these things you check that are not there. You check it on the other, or write something there. Is it very clear?
Yes.
Yes, Dr. Mac.
Okay, scroll down, please, Mr. Nyame. So primary approach is that you're going to use, what approach are you going to be using in this case? This case seems to be that the case is problem focused. What are you going to do? Anything else you're going to do in terms of a multidisciplinary approach? Is it what's the problem? Are you going to have him refer to a doctor? Does he need medication? Does Johnny need medication?
No, Dr. Matt.
Will medication help deal with his anxiety?
Dr. Matt, I think it depends on the level.
Why would he not need medications?
But at his
Why would
age,
Johnny
Dr.
not need
Mac,
medication?
At 11, you would give an 11-year-old anxiety tablets?
I think, well, he has any
because there might be side effects of there could be side effects of suicidal ideation and all those kind of
Where's the evidence? Where's your evidence of that?
No, I'm saying if you give it the medication that they have on the market, no. Sometimes when you take it for anxiety or depression or whatever the problem is, so the side effects sometimes might result in feelings of suicide or maybe depression or so on. So I'm saying for an 11-year-old, would we want to give an 11-year-old medication? I'm just asking.
Well, the question is, does he need medications?
I don't think so. I don't think so.
Okay, so so in other words, how are we going to treat the bedwetting? The bedwetting is, we have to determine, is the bedwetting a physiological cause or is it an emotional cause? Okay, but then how will you treat it? One way is medications to treat it. Yes, I'm not saying that you're going to try therapy. I'm just saying that you have to weigh a number of issues.
Okay.
So the treatment plan is saying that this is one option to treat it. So if the parent says, no, I don't want my child on medication, then you say, okay, then you make then it doesn't, but you don't limit yourself in your treatment.
So then, Dr. Mac, the bedwetting could be clearly it's physiological because it's happening, and also emotional at the same time.
Yes. Well, but medications can treat bedwetting.
Okay.
Because if you try therapy, it doesn't work. You may not have to refer them to a medical specialist. Is there anything else you need to do? Anything else? Do you need to advise the parents to come in?
Yes, Dr. Mark.
Does the parent need anything? Any other treatment for the child?
I'm sorry, Dr. Mac.
Any other treatment for the child?
Are we using the primary treatment approach section? Is that where we are at?
What?
Are we at the primary?
We're on medical, psychological. We are medical.
No. Oh, Lord.
Yes, I'm past there. You need to focus. Past there.
I am focused. So I didn't know that you passed there.
Okay, so we have medical. So anything else, any other treatment we need to check to make certain that this child needs help? We need to consult the school. We need to consult the school about this problem. So we need to consult the school. So we check other guidance counselor. So we may need a treatment. We may need a consent for treatment to contact the guidance counselor about his performance at school. All right, and that also has to go on the treatment plan.
Okay.
Now this is this intake is at DSM-4. But anyway, so what we will do is that we only need to have access 1. Now, what is the diagnosis for Johnny Walker? Let me hear it.
Generalized.
And what evidence is there in the VINE that is a generalized anxiety disorder, ladies and gentlemen?
Because it means.
Anybody has the DSM-5 in front of them? 300.02. That is the North American code, and the F code for the ICD-10. Can somebody look up the criteria for generalized anxiety disorder? You have your cases in front of you, relate each to that it makes certain that what is in the VINE confirms, the DSM confirms it. Not the DSM, not going to the DSM to pick up something. Doesn't work that way. So let's go.
Dr. Matt, the DSM confirm it.
No. I want to hear it. It must be music to my ears. So read it, please. By the way, why is it not separation anxiety disorder? Anybody?
Because it was mentioned that when he was separated from his parents, he never had any difficulties when he got back to them. There's a section that says during the first day at prep school, when he was 4, he was able to separate from his parents without difficulty.
Okay, so stop it there. That is known as pre-morbid functioning. That there in that video is known as pre-morbid function. You are able to determine that this young man never had an issue of attachment before. It's assumed that the attachment was secure. Are we in agreement?
Yes, Dr. Mark.
Yes, we are in agreement.
Okay. Could you go back further up, Mr. Name, please? We're going a little further. Okay, let's stop it. So we have the 5 axes. However, for this class, you won't normally use it in a formal setting, but for this class, what do you think? What other diagnosis is there? Yes, go ahead. But I'm asking, is there any other diagnosis? Is there any other diagnosis?
Dr. Mark.
Dr. Mark, we talked about family.
I didn't hear that. Are there any other DSM-5 diagnoses in the case?
Dr. Mark?
Yes.
Okay, when we were looking at it, to be honest, I saw 1 or 2 symptoms of PTSD, but because the overall thing was more the confirmation for generalized anxiety was there, but I saw at least 1 symptom of PTSD.
What PTSD is in the veneer? I don't know of any PTSD in the veneer. Do you know where that is coming from?
What about when he's constantly when you look at the criteria for post-traumatic stress, under one of them it says that the person can be anxious based on not they themselves having gone through the trauma, but a family member having gone through the trauma, and the fact that his mother had the car accident. I even at least one of the things there kind of look like a symptom of PTSD. I'm just saying.
Justify that. I'm not seeing that at all.
I'm not looking at the DSM-5 right now, but
okay, but do you have it in front of you? We need to look at it now. Do you have a DSM-5 in front of you? And I'm asking, is there another diagnosis in the case? We have 1 so far. Is there anyone else? Is there any other diagnosis? Okay, but apart from those, is there another diagnosis?
Bedwetting.
So what is the proper Axis 1 diagnosis? What type? What type?
Elimination disorder.
No. So it's on the category of elimination disorder. Could someone, if you have a DSM in front of you, find elimination disorder and look up what type? What's the specifier meaning type?
NUE.
So we have, but what type?
What type?
What type of NUE is it? All right, let's look at the criteria for generalized anxiety disorder. Could you read it, please? And relate it to the veneer. Go ahead. Stop it right there. Hold on. Is there any evidence in the veneer? In terms of duration of onset, Continue. Continue. Stop it there. Does Johnny have issues with controlling worry? Okay, that's an anxiety. That is anxiety, not separation anxiety. That's anxiety. That's what's called it's called free floating anxiety. Continue. One. One. Go ahead. Go ahead. Stop it there. Is that evidence in the video? Continue. Do we have any evidence in the video?
No, I never mentioned anything about fatigue.
Okay, so but it may not show up in Johnny, but may show up in another child. So continue.
Yeah.
Okay, so do you understand why he's having trouble at school? That explains the academic problems. Continue. Yes. Okay. So did you satisfy that criteria? Continue.